This video is part of a series of evidence-based resources to share worker voices and supports the U.S. Surgeon General framework on addressing workplace mental health and well-being. I'm Dr. Lisa Jaegers, professor, occupational therapist, and advocate for health and well-being. I discuss published research on how to detect trauma, also called critical incidents, and ways to address it. Use the bookmarks to find the content most useful to your interests. I presented this at the Total Worker Health Symposium held by the National Institute for Occupational Safety and Health at the National Institute of Health campus in Bethesda, Maryland. Shift gears and talk about a total worker health needs assessment to identify exposure to work-related trauma and violent critical incidents experienced by prison workers. Myself and Mazen, Jared, and Martin were all co-authors on a publication related to this. So I want to recognize funding through Lindenwood University's Hammond Institute and acknowledge our participatory team and grad students for their help. So I just want to note that the work that I do is under the Transformative Justice Initiative umbrella, and the intent here is that by bridging corrections workplace health and a transition philosophy over to reentry and the experiences of people incarcerated, there are certainly intersections there for us to consider the full workplace and scope for correctional officer health and beyond. So I do want to suggest that we proceed with caution. I will be talking about sensitive critical incidents, and so just know what your limits and boundaries are in terms of hearing that information. So critical incidents include violence, can be described as trauma-inducing experiences, and have been recognized as a significant workplace health problem. And also, corrections workplace critical incident exposures, they're typically not tracked or reported with detection tools or methods, and so therefore we don't have much data about them. We don't know much about them for addressing worker trauma. So as a little more background, the National Occupational Research Agenda does identify that the incidence and impact of violent encounters during daily interactions for correctional officers are of interest. And so using a total worker health approach can be one method for addressing this. So my research questions for this include exposure to critical incidents. What is the prevalence there? Is there a difference in exposure to critical incidents between custody and non-custody staff? And then are there differences in job satisfaction, health outcomes, and health behaviors for individuals who report having experienced ACI, and as compared to those who did not? So the methods of this project were, it's a cross-sectional study using a purposive sample. This was part of a larger total worker health project at a facility that's community corrections, a 350-bed facility where people leave during the day and come back at night. There were 23 members on a participatory team. All staff were invited to participate, and I offered $20 gift cards for survey completion. Of course, we try to use trauma-informed practices as much as possible and offered mental health resources as well. So just to clarify, custody personnel in this case for this study include those who primarily work in the department, the detainment and housing areas, so that's where people are under custody. And then the non-custody personnel are those who work at the administrative and treatment side of the facility, and they can be probation and parole officers out in the community as well. So the measure that we used was adapted from the Critical Incident History Questionnaire that was created for police officers. So we found that there aren't any tools available for correctional officers specifically, or correctional workers. So we adapted that tool and scaled it down from 34 items to 11 and offered an open-ended option. And this was in an attempt to reduce the potential harshness of wording and limit the number of times trauma-inducing words were used, but also look at efficiency and potential use for a quicker use situations. So in addition, on the survey, we had a 2-item PTSD checklist, an item to look at musculoskeletal back diagnoses. We asked about work absence, sleep, and then job satisfaction and job title. So the results of this project, we had an 81% return rate, 89% provided information related to their critical incident experience, if any. 60% were custody staff, 60% identified as female, 72% identified as African American or Black, 81% were older than 41 years, and then 49% worked 6 or more years at the facility. In addition, for the work and health-related characteristics, we had 59% who reported experiencing a critical incident, 44% screened positive for PTSD, 64% were absent from work 1 or more days in the past month, 42% were dissatisfied with their job, and then 46% were sleeping less than 6 hours per day during the work week. So across all CI outcomes, we found that more custody staff experienced critical incidents than non-custody staff. CIs were reported as occurring most often in terms of coworker injured, seeing someone dying, and life threatened. This is a breakdown of all of those critical incidents and by frequency here. So as you can see in the first column, never, that means the person responded they had not experienced that. Then we get into these frequencies of 1 to 9, 10 to 50, and more than 50. In the second range, they had experiences anywhere from 1 to 9 times. The highest range was in that 27% seeing someone dying, and then in that 10 to 50 times range, coworker injured, and then more than 50 times we see exposed to diseases and such. So the differences in the types of critical incidents across all CI outcomes, we saw that, and there were significant differences in occurrences between custody and non-custody staff for direct trauma categories like seriously injured and exposed to diseases and other indirect traumas. So within the non-custody staff, more administrative staff reported seeing someone dying, sexually assaulted adult, whereas more probation officers reported life-threatened, coworker injured, and badly beaten adult. So our findings show moderate to high prevalence of CIs across all staff, reporting among 19.5 up to 59%, and then no significant differences between groups in half of the CI categories surveyed, such as life-threatened, coworker injured, seeing someone dying, and badly beaten adult. In terms of job satisfaction, we saw indications that there were significant differences across all CI categories except one, with the mean scores of job satisfaction for the significant critical incident categories lower for those who did report a CI than those who didn't. So as you go across each of these, you'll see how the reported CIs versus not reported, you're going to see lower for job satisfaction, higher PTSD scores, and so on. Additionally, when PTSD was considered as a health characteristic, there were significant differences in 5 of the 11 CI categories, and so on. So for work absences, there were significant differences in 3 of those CI categories, 9 for low back, and then 9 for sleep. So in conclusion, the prevalence of CIs among correctional staff was high. It didn't matter where they worked, they were reporting CIs. There was a broad spectrum and variation of those critical incidents, and then exposure to workplace violence, those dangers and trauma-inducing experiences, we know that those may contribute to acute stress reactions. So PTSD, lack of sleep, musculoskeletal low back pain. Also, those significant relationships were found between all but one of the CIs and low job satisfaction. This could help describe things like why we're seeing such high turnover in corrections across the industry. So implications for this, we need more holistic worker-informed interventions in this space, tailoring approaches depending on severity and the context of that critical incident. But as you saw, we didn't measure severity. So that could be a way to further refine this critical incident survey tool. And then also looking at ways of integrating the workplace, worker, the detainees, and community needs to inform all of these different areas. So this is just an example of multi-level solutions that we could consider. In that primary prevention area, we could be looking at a national level for standardization of critical incidents for reporting injury and fatality data. We could be looking at trauma-informed care across prisons and jails. And then at that secondary prevention level, we could be using a tool such as this critical incident screening to detect CIs. And if you think about the way that workplace health is done, when someone sees a physician for an injury, oftentimes there's a screening tool where they ask a few key questions. Well, maybe there's a way that we could do that through secondary prevention to detect what might be going on. Perhaps these could be utilized for setting restrictions for return to work and informing the way that we provide care to individuals. And then of course, in that tertiary level of care, there needs to be more rehabilitative, depression management, PTSD therapy support groups, more prominence in that employee assistance program, those programs, peer counseling support groups, and stress reduction units for correctional officers. So just a few ideas. If you want to learn more about the study, it is in publication, so feel free to go to there, and you're going to learn quite a bit more about it than I could present in 9 minutes here. So that's all I have. Thanks. See the show notes for more, and subscribe to this channel for additional health promotion content. Take care.